Hello, everybody. I'm Dr. Rob Silverman. I've got special guest today, Dr. Brent Dorval. I'm so happy to have him. He needs to give us some updates. He is the Chief Science Officer at KBMO. As everybody knows, I am speaking about their antibody test, and he's here to tell us what's new in the area of testing, especially testing with antibodies and KBMO.
Hi, good morning, everyone, and thank you, Dr. Silverman. I appreciate the opportunity to speak with everybody this morning, and I hope everybody in the audience is well and staying well. The first update I'd just like to share is something brief that came in yesterday. We had some testing results from a major medical lab at a Boston teaching hospital. Dr. Kellogg is the medical director, lab director of the clinical lab at this hospital, and we had basically gifted him about 600 tests so he could run them through the paces in his clinical laboratory. And he had some very nice results, which confirm what we're seeing in-house. He saw a sensitivity in the high 90s, around 95%. And he saw 100% specificity with about 400 tests to date. So we can't mention a hospital. We certainly can mention his name, and it is indeed a major, major hospital. So we're very, very happy. And he did this. This was an arm's length transaction. We had no knowledge of basically what he was doing other than testing in his laboratory. So this is just an independent confirmation. So we're very, very happy, with those results. And those results will be posted, if they're not, they'll be posted to the KBMO website so that everybody can view them for themselves. So that's hot off the wire, so to speak. And then today, there's been some interesting developments around both humoral, meaning antibody, and cellular immunity. Now, heretofore, people have really focused on the antibody response to COVID-19. And that's very interesting and certainly a very, very important feature of this disease. But what's really been lacking is, okay, what's the other arm of the immune system doing, meaning the cellular immune system? And not a lot of papers have addressed this thus far. And Dr. Silverman and I unearthed a paper recently that's a very, very nice example of the interaction between humoral and cellular immunity. Admittedly, it's a small study, but nevertheless, it's elegant. It makes a point, and it certainly begs the question that if this sort of interaction is indeed occurring, that future studies are indeed warranted. The study I'm talking about is one published by Ling Ni, last name N-I, in Immunity, and that was just earlier this month, and it's detection of SARS-CoV-2 specific humoral and cellular immunity in COVID-19 convalescent patients. So what they did was they studied a cohort of 14 patients that were PCR positive and then hospitalized due to the severity of the disease. Now, they had the typical symptoms that we've seen in COVID-19 patients. They had fever, they had lung sort of involvement, dyspnea, nasal types of sinus congestion, those sorts of typical symptoms that accompany this disease. So they were hospitalized as a result. They recovered, and then they were later released from the hospital. What they did was a follow-up with this cohort a few weeks later, and then they wanted to take a look at the antibody response as well as the response of the cellular immunity. That's with the T cells, and in particular NK cells / macrophages, which are the natural killer cells. Those cells bind to antigens, they engulf them, and they directly kill them, viruses, bacteria, and other types of antigens. The indicator that they used here, they did something very, very interesting. They broke the humoral immunity into the 4 subclasses of IgG, which again, this is novel in and of itself. They looked at IgG1, IgG2, IgG3, IgG4. And as a marker of cellular immunity, they looked at the production of interferon gamma by these T cells. So what they did was they stimulated these T cells with nuclear protein, with the S spike protein, the receptor binding domain, or another protein, they call it M-Pro or 3CL. That is the major protease that's inside the COVID virus, so that when the virus produces this long polyprotein as a single transcript, what happens is this protein then cleaves it into the various proteins, the structural, enzymatic, and some of the other proteins that are in the virus. So it's they call it M-Pro, or the major protein, major enzyme in this virus. So that's the function of that. It happens to be a cysteine-based protease, but that's beyond the scope of what we're talking about. So that's the take-home message. So they looked at three major proteins, and so if we just take a look initially here at the humoral response, what we found is there was IgG and IgM response in a broad sense against the SRBD. So that's the spike receptor binding domain protein. And as you probably remember from the last time I gave a presentation and you saw it, is that the receptor binding domain is on the outside of the coronavirus, and that's responsible for binding to the ACE2 receptor on host cells, which now, once the virus binds by the RBD, the receptor binding domain, it can then undergo further proteolytic processing, and then it's engulfed by the cell, and now you're set up for infection. So the importance of the antibodies against this particular domain is that if you have antibodies that bind to the receptor binding domain, they inhibit the binding to the ACE2 receptor, and they prevent infection. This mechanism is so-called a receptor blockade. So you might see it termed as that elsewhere in the literature. And that just simply means you block the receptor on the receptor domain on the virus. It doesn't bind, and you don't get infection. Now, they also got a good response, antibody response, against the nuclear protein, as you would expect. The COVID-19 test that's offered by KBMO Diagnostics measures the IgG 1, 2, 3, and 4, by the way. It binds to all subtypes of the COVID-19 nuclear protein, and that's what's measured on the KBMO diagnostics test. So they found good response, both IgG and IgM, against the nuclear protein. Now, curiously, they did not get any appreciable response, IgM or IgG of any subclass, against the M-Pro, the 3CL major protein that's inside the virus. Find that kind of peculiar, a little surprising, but that's the result they got. No appreciable response. But as you'll see, the plot thickens a little bit, and it gets a little more interesting when we talk about cellular immunity. So what the take-home message from the humoral side of the immune system is that neutralizing antibodies are produced against the S spike protein receptor binding domain in their pseudovirus assay, can inhibit binding and prevent infection of those cells. The antibodies against the nuclear protein do not neutralize the virus and do not prevent infection of the pseudovirus cells that they use as their model system. And again, the M-Pro had no antibodies and basically went undetected on the humoral side. Now, if we take a look at and I wanted to say that there was another interesting article that came a few weeks later by Fatima Armanat at Mount Sinai, and she basically showed that there was an IgG1 and an IgG3 response against the SRBD domain of the spike protein on coronavirus. So it essentially confirms a lot of what Ling Ni saw in this paper in immunity. So the overall conclusion is there's neutralizing antibodies that are against the SRBD, and for nuclear protein, there's antibodies, but they're not neutralizing. Now, when we take a look at the cell-mediated immunity side, the way they did this is they did an interferon gamma producing assay. So what you do is you take T cells, you isolate them from each patient. That's called the Buffy coat, so the white cell coat. You remove those, and then you stimulate them with either the SRBD protein, the nuclear protein, or the M-pro protein. So you stimulate those cells, and then you do what is called an L-spot, and that's just a fancy assay that will measure interferon gamma. So what they're looking for is these cells to be stimulated by their respective proteins. If they produce interferon gamma, you know that those T cells are primed and are waiting to see that antigen in vivo, and then they immediately produce interferon gamma. And what do we know about interferon gamma? Interferon gamma is a potent virucidal cytokine in vivo, and it also activates a variety of other cells, B cells, T cell, other T cells, macrophages, so that they are kind of armed in the presence of interferon gamma, and they're ready to even potentiate the interferon gamma response. But that's the main response of this particular cytokine. So what they found here was something very, very interesting. So they stimulated the cells in all these patients, and what they found was that they got cytokine production in T cells that were primed and ready for the receptor binding domain, the nuclear protein, and also the M-pro. So if you remember before, M-pro had no antibodies. They say, oh, well, maybe that's not very important in the immune response. And that's what we would have concluded if you looked at previous studies, because they hadn't looked at cellular immunity. But if you look at the cellular side, now, as I said, the plot thickens a little bit. What happens is that M-pro provokes a very, very potent interferon gamma response, so that it's not just silent. It provokes this response. It definitely engenders a virucidal activity, and then it also interacts with other T cells and B cells to help potentiate the antibody side, as well as potentiate the natural killer side of the system in cellular immunity. So what this paper has done, I could go into the details, and I think that's beyond the scope of this discussion, but what I wanted to leave you with is that what they've shown is that there's a humoral side, and these proteins provoke antibodies. They're IgG1 and IgG3 predominantly, IgG2 and IgG4 much less so. So remember, IgG1 and IgG3, I'll get back to that in a minute. But those proteins, all viral proteins, also provoke a potent cellular response. So the take-home message is that both humoral, antibody, and cellular side through cytokines, probably other cytokines beside interferon gamma, maybe interleukins like interleukin 16 and other interleukins, other people will elaborate on this study and show that not only interferon gamma, but there'll be other cell-mediated cytokines and responses that'll be very, very important in COVID-19. So antibody as well as cellular-based immunity is going to be very, very important in diminishing or maybe not preventing, but certainly limiting COVID-19 in patients that have been infected. The other thing that comes out of this study is that they followed these patients for at least 2 weeks, so they know these neutralizing antibodies against the S-spike RBD protein are present for at least 2 weeks. And again, as these studies are ongoing, and they study cohorts longer, they'll be able to, is it 2 weeks? Is it 4 weeks? Is it 10 weeks? So they'll be able to elaborate on the time frame to which people have these neutralizing antibodies. Now, I mentioned that the major response here against both nuclear protein and spike is IgG1 and IgG3. And what we know is that these antibodies activate complement very, very strongly. They activate C3. So what happens is the antibody binds to antigens, in this case coronavirus, binds to the virus, activates complement, and C3b will be deposited on the surface of the virus and also the antibody in the vicinity. And what happens is, and again, this is kind of hypothetical, nobody's shown this yet, but it happens with immune complexes is they activate complement once, antibodies bound, IgG1, IgG3, very strong activators of C3. C3b is deposited. These immune complexes then are processed by various cells in the body, macrophages and other types of cells. But there's a mechanism called the immune complex clearance mechanism. The C3b binds to red cells, and then these immune complexes are composed of C3b, IgG, and antibody will be shuttled to the liver and spleen and degraded there. So I think as time goes on, somebody will look to confirm that this mechanism is operating in this viral disease, much like it does in other viral diseases and other immune complex diseases. And what's interesting, even a little further, is IgG2 is a very weak activator of complement, and it's not produced to any appreciable extent against any of these proteins I mentioned. And also IgG4, which is thought to be a protective antibody. It does not activate complement at all, and also was not produced in this particular study, in this particular cohort of patients. So, and when you look at Fatima Armanaz, she also find IgG1 and IgG3 was produced as the predominant isotype and not 2 or 4. So I think that the picture that's going to be painted moving forward is G1, G, and G3 are going to be the predominant response, and that a clearance mechanism that is that I'm postulating right now through C3b and the immune complex clearance mechanism is probably going to play a role in this disease, again, much like it does with other disease. It will be very consistent. So I thank you, everybody, today. I appreciate you listening in early on a Friday morning, and I hope to talk to you in the near future again. Thank you again.
You definitely will. That was a great dissemination of the information. I'm just going to synthesize this a little bit because it was so much. I want to make sure that I have the points in the order that we like it. So the takeaway here is if our immune system functions in balance and appropriately, we should have for lack of a better term, a good quality positive immune response to the virus.
Oh, yes, absolutely. It's a very robust response, and the predominant isotypes are IgG1 and IgG3 in this paper and in a subsequent study.
So essentially, you shouldn't get that sick if your immune system is functioning well. And now we know the specific subtypes of the antibodies to test for, and you are testing for those. Those we test for IgG1, 2, 3, and 4. So all subtypes of IgG are tested against nuclear protein on the KBMO diagnostic test. Yes. And we have cell and humoral immunity. So that's the two different arms. So one is innate.
Yes.
Cell.
Yes.
Which is those macrophages and everything that you talked about. So the initial guys that come out, they're sort of like your search and destroy. And then
yes.
You've got your adaptive, which is your humoral B and T cells.
That's correct.
And those are recognize and remember. So the memorization is the antibodies. And that's why those antibodies are so bad, because it's memorizing it's memorizing what's happened. So therefore, if it happens again, it's sort of, our own antibodies occur either when we have our own immunity and or when they do a vaccine. We're not going to go down that rabbit hole. But the whole
Right.
is to make these antibodies.
No, that's correct. And if I could just elaborate on one point, I mentioned that IgG1 and IgG3 form immune complexes and activate complement. And what do we know when that happens in almost all other diseases? Is it generates a fever. So what I'm wondering is, during the initial phase where people are maybe feverish, are they producing immune complexes and activating complement during that phase? And in some way, the complement activation is at least in part responsible for some of that fever. I know fever is early on, but I think fever can progress in several stages. I mean, I've heard patients say that they've been feverish for well over a week. So I'm wondering if that is coincident with what's going on with immune complexes. And if it were, it would be consistent with what occurs in some other diseases.
So we're expanding our knowledge to get into that complement as part of our body's response. And we want our body to respond. Again, I'm just going to keep hammering on the point to everybody. One of the key factors to this is, obviously you don't want to get it, you want your barriers, but what's inside is your body's immune system ability to rectify this pathogen, this foreign substance. And that's why the people with the comorbidities are having a tougher time.
Yes.
And everything like that. And the S protein is different than the N protein. The S is the spike. It sticks in. Why don't you tell them what the N is?
Well, the N protein, again, sorry, I didn't go into detail there. The coronavirus has a circular nucleocapsid composed of positive mRNA, and it's kind of wound inside the circular viral capsid. And then along the length of that RNA, kind of like beads in a pearl necklace, is the nucleoprotein. And that's a regulatory protein for translation and that sort of thing, transcription in that virus. So that's an internal protein, but it's also a protein where you get an antibody response very, very early in infection.
And those antibodies, typically IgM early, IgG late. So in theory, in a perfect graph, IgM's day 7 through day 21 and IgG day 14 to 28, in a perfect graph.
Yeah, in a perfect world. And again, other studies have come out recently. When you look at a cohort of patients, they're all over the map in terms of exactly when they produce IgM or when they produce IgG. But in general, that's an accurate statement.
And you used inhibit IgG. It's a receptor blockade. So what you're saying is IgG actually blocks the ACE2 inhibitor, and that's why we want one of the reasons that we want IgG. It's actually stopping the spike protein from connecting to the ACE2.
Yes, that's correct. So the IgG binds to the receptor binding domain on the spike protein, so it covers it, if you will, and it's called a receptor blockade. And now it can't bind to the ACE2 receptor. It doesn't undergo proteolytic cleavage, and then it cannot fuse with the host membrane, and just ultimately does not or is incapable of producing infection.
So that ACE2, it's very tight. That was one of the big problems. The S got in really tight, and then it produced those proteolytic enzymes, if you will, of furin, and then that furin goes in. Now we're really signifying the 3PL.
That's correct. 3CL, yes.
So that's what's going on inside, and that's when the damage to the virus is done. So we take KBMO tests for IgG.
And IgM as well.
Right, both. But they talk about tighter amounts. Is that as important? Or, I mean, everybody's been asking us, what's the tighter amount? Because there's a lot of tests out there, and we know some of the tests haven't been as effective. Mm-hmm. We're going to go over that test again at the hospital. So if you can that.
What we know is that by about day 14, and especially day 28, that virtually everybody, meaning 100% of people by day 28, are positive and have a strong immune response for IgG, all of them. So this particular test at KBMO, I think the best use of this test is really early if you know that you're like PCR positive, wait maybe 5 days, 8 days, you should see IgM. And if the person is sick or has been sick, but PCR negative or has never been tested for PCR, test them later. Test them 2 weeks out after their symptoms. Test them 3 or 4 weeks out, and then you should catch maybe the tail end of M, but certainly IgG. So again, we talked last time, I think, a little bit about the windows in this infection. The window for PCR, again, is going to be early. And if you're good at taking the sample, you're going to get it early. There's a lot of variability depending on who actually takes that and where you take it from. But if you take it early, you know, right around the time of fever, and then if you test maybe 3 to 5 days later, you should pick up IgM. So in that case, in that scenario, you should be PCR positive as well as M positive. Now, like if you miss that window, it's not that that test is bad or an antibody test is bad. You may just be into another phase of this disease. And so you may want to structure your sample taking so that you understand that, and you say, okay, let's catch the next phase of this. So we think you're infected, stay home, kind of shelter in place. Let's test you at 2 weeks, 3 weeks out, and let's look for an IgG response. And if we see it, we know that you're in the convalescent phase at that point. And this test has been very, very good in its agreement with PCR. That was the other recent development, and it's just been submitted to FDA for the emergency use application, which is under review as of still yesterday, and it had a 94% agreement with PCR. So that is almost as good as you get. So this test, if you PCR positive and antibody positive, or PCR negative and antibody negative, about 94% of the time, this test is going to be predictive of that. So clinically, a very, very useful test.
That's a great takeaway. And because you mentioned those numbers, we started out with the numbers with the hospital and a doctor in Massachusetts.
Yeah.
We said specificity, so that meant it was 100%. It meant there was no false negatives. And that's the problem. You don't want a false negative because somebody's positive and walking around and infecting everybody or possibly infecting everybody. So it was 100% with 400 people in that setting, and 95% sensitive, meaning only 5%, 1 in 20, could conceivably have a false positive. And in the hospital, they're also taking the swab test.
That's correct.
400. So that's at the top of the list. And so what you're saying is you're very comfortable with those kind of numbers, that the test is accurate and it's a choice test to do. Because
and for this,
go ahead.
I'm sorry. For this particular individual, Dr. Kellogg, we gave him those tests because we wanted to have him test this in his own lab. Frankly, I knew it was happening, but I had no idea what was going on, and I just saw the results. So we got that sort of result in our lab. I was personally involved with the testing. And so what we didn't want to do is pollute the data with a subjective interpretation or any sort of bias. So we gave him these tests. He structured the study himself without any help by myself or anybody at KBMO, and we wanted something totally independent because most of these tests have been, that I'm citing, clinical anyways, have been done in China. And people today are saying, oh, the tests are bad, and do you believe the data, and that sort of thing. So it's very, very important, really, even for the manufacturer in China. I think this is validation for them. If you can send it a continent away and have people in our lab validate it, a major teaching hospital in Boston has validated it. I think that speaks well for the quality of this test. And I think it's important in this environment just because I think the tendency is to slam China. Some is due them on at some level, but not at others. So I'd say let's do this in a rational way and do it at arm's length, and let's see what happens. And that's what was particularly pleasing.
And both tests on continence were almost statistically the same.
In fact, the one over here was better.
So there we have it. That's fabulous. So
yeah, I've been in science for a long time, and you always have to be careful when you analyze data to not say, oh, that's not what I want, so let's throw that one out. That wasn't quite right. So you got to be very careful how you pick and choose a flyer, something that you say is atypical. And my philosophy always was put all the data in and report it as it is, and don't try to stack the deck, because I would rather have somebody get better results than I got than say, wait a minute, the results are worse. And that's always the way I think a good scientist will say, put all the data in, let's not pick and choose, and let's see where the chips fall. And so in China, they got 87.3. Here you got, I guess, almost 95. In China, they got in the high 90s. In one study, they got 100. Over here, you got 100%. So the results are better. So I think people should have more confidence in the quality and the statistics from this test now.
Well, that's like I always said, that's why you test and you don't guess. And if
That's
you
right.
analyze the data, like you're saying, and it's real data, you can make an informed decision and possibly a hypothesis.
Right. And can I bring up one other point while we're here? I don't want to belabor it, but we're seeing some discrepancy between tests, not just ours, but other tests out there. And so what's happening is, I'm going to pose this as a question more than anything else. So what another paper has shown is that depending on the viral load, meaning a high exposure or low exposure, or depending on the protein, the S protein or the N protein, you get variable lengths between the time you're exposed and become positive. So here's where I'm going with this. So if you have a test that measures spike protein that was positive, it could be negative for the N protein, or vice versa. We're seeing, because in one case, the spike protein may become positive before the nuclear protein. It's not typical, but it can. In other times, we see a positive nuclear protein before the spike. So I think we have to be careful about saying, oh, their test is no good. The appropriate question is, what are they measuring? What are they measuring it with? And so when clinicians say, try to compare one test, an Abbott test or a Roche test, just be careful. Ask the question, what are you measuring? Is it a spike protein antibody? Is it a nuclear protein antibody? Or is it something else? And then that will help you make sense of the diagnosis. And be careful not of saying, well, that test doesn't agree with that test, so one of the tests has to be wrong. I'm thinking they both can be right. It just depends on when you're measuring that particular antibody and what antibody you're measuring. Now, what we don't know about some of these other tests, and I've looked at many package inserts, is what are they measuring? And we're going to put this in our package insert. This test measures IgG 1, 2, 3, and 4. I don't know what those other tests measure. Do they measure, depending on the variability of what they measure, that also could explain some different results. Maybe if there was a negative, maybe they're only measuring IgG1 or IgG3, or they're using a different epitope on an antibody. Maybe it's a cross-reactive epitope. I don't know. So I'm just saying there's a cautionary tale here. Tests may not be good or bad. It's just a question of what you're measuring and what you're measuring it with.
Absolutely. I mean, blood labs are great, but again, what are we measuring? So you guys are measuring COVID-19, IgG 1, 2, 3, and 4, and IgM, also IgM.
Yes, and IgM.
You know the stage and where you're at, and that gives you a good disclosure of what's going on, and it works very effectively in sync with the swab test. It's pretty funny because in the news yesterday, they were talking about the administration, about long and short swabs and everything like that. And you spoke to examiner. It is a possibility of examiner fault in that everybody's, this is blood. So this is very objective, if you will.
That's correct. And the other development, I don't know if I mentioned it in the last video that we did, is that we have the blood spot test. So that's very, very important. We can send a kit to your home. So the doctor orders the kit. We send it to the patient's home. You don't have to expose the phlebotomist. The patient doesn't have to go to the emergency room or expose people in the clinician's office. So they can just take a finger prick at home. They put a blood spot on a Wattman filter paper. They dry it, put it in the mail, send it back to us, and in 2 days we have the results. And what we've shown is there's over 98% agreement between the serum test, whether it's plasma or serum, and the dried blood spot test, because we figured out how to extract those antibodies from the filter paper, IgM and all the IgGs, so that there would be almost a perfect concordance between serum and dried blood spot. So I think that's an important development for the company and the clinicians. It's just a beautiful thing, because now the patient can do it at home and they expose nobody but themselves.
Right. We had the serum. I took the serum. So
yes.
To expand on the point, you have the option of having a phlebotomist come to. They're all geared up, so no one has to worry about anything. They were wearing everything. I'm in the office. They were wearing nets over their head, etc. So you can get the serum. You can get the test in a day. So if you order it today, you get it tomorrow.
Yes.
And then you'll have to wait for the phlebotomist, which is your choice. However, with the finger stick, you can then stick your finger, put it down on the piece of paper, if you will, put it right back in the mail, gets right back to you guys. You'd turn it over in a 24-hour period, and me as the practitioner will have the results in a very quick turnover. So it's literally like a 3 or 4 day turnover. Most of my patients now have opted for the finger stick. So I'm going to tell everybody how they can get in touch. It's kbmodiagnostics.com. If you're a doctor, it's doctor registration. The promo code is COVID-19, not a surprise, / Dr. Rob. If you're a patient and you're watching this, do me a favor, reach out to me, DM me, and I'll give you a code to get the test. Dr. Dorval is overseeing everything, so you can guarantee pure science and efficacy. I'm giving you that as a without question testimonial. Okay. I really appreciate you coming here, and we've got to get you back on when this dies down a little bit, so to speak. And we got to get you talking about the FIT test and Zonulin and all that, which you're known for, because you're known for rapid tests.
Yes. Thank you.
My pleasure. So everybody, it's always my pleasure. Do me a favor, like it, make a comment, ask a question. I'll get them to Dr. Dorval, and without question, share this. It's been my pleasure. Dr. Rob Silverman, always yours in health.